Good evening, everyone, and welcome to the 40th Annual DeVos Medical Ethics Colloquy. My name is Dr. Kathy Moran, and I serve as the Associate Dean for Nursing Research, Scholarship, and Lifelong Learning at the Kirchhoff College of Nursing here at Grand Valley State University. Our college, along with the College of Liberal Arts and Sciences and the College of Health Professions, serve as your GVSU hosts for these colloquy events. The topics covered during the colloquy directly impact our interprofessional healthcare providers, our students, and those who are actively serving our community. We are pleased to provide the venue to continue these informative events. I'd like to extend my special thanks to our Colloquy Planning Committee for their ongoing support and leadership of the DeVos Medical Ethics Colloquy. We'd also like to recognize and thank this evening our major sponsors, Trinity Health and Corewell Health. For the Q&A section of tonight's event, we will have individuals available with microphones to assist you in presenting your questions to the speakers. Finally, if you're interested in receiving continuing education credits for this event, please be sure to follow the instructions provided at the registration table just outside this ring. To give our opening remarks, I'd like to introduce Dr. Farr.
As Dr. Moran said, this is our 40th semi-annual colloquy, and this started in 2005 at the behest of Richard DeVos, who asked Dr. Luis Tomatis. Here the picture of both of them, Mr. DeVos sitting and Dr. Tomatis standing. He requested that we start talking about medical ethics back 20 years ago. And twice a year, we bring topics that are timely, and we love to have the diverse audience that we're having now. I'd like to thank Grand Valley, especially the Dean, Linda Lewandowski, and then the Associate Dean, Kathy Moran, for their help in organizing this and seeing that we pull this off. But the guy that deserves the most credit intellectually is a man who is an associate professor, Jeffrey Burns, and I'll introduce him now.
Thank you very much, Dr. Farr and Dr. Moran. And thank you to the DeVos Committee, Colloquy Committee members for their support and making this possible. I have the pleasure of introducing our moderator tonight, Dr. Michael Dickinson. Dr. Dickinson is a board-certified cardiologist and a fellow of the American College of Cardiology and Heart Failure Society of America. For many years, he was the medical director for the Corewell Health heart failure programs, during which time he helped develop and launch the heart transplant, mechanical circulatory support, and advanced heart failure programs. More recently, Dr. Dickinson has shifted into a strategic outreach role, working on expanded access for patients who can benefit from advanced heart failure care. Dr. Dickinson earned his medical degree from the University of Michigan School in Ann Arbor, and followed by service in the U.S. Navy. And he then completed his internal medicine residency at Blodgett Memorial Medical Center across town and St. Mary's Health System in Grand Rapids. He completed his cardiovascular disease training with Michigan State University in East Lansing and completed his advanced heart failure and transplant cardiology fellowship in the Cleveland Clinic in Cleveland. And I have seen him at work in the hospital, and he's an all-around great guy. So I'd like to introduce you to.
Thanks so much, Jeff. It's really an honor for me to moderate this event. So I'm just going to set the stage here for just a quick second. This is going to be really fun and exciting. The topic we have tonight is one that will stretch you and stretch your understanding of medical ethics. And I am just thrilled to have our two speakers who are here, because I'm going to sit and enjoy and learn from them and watch how they think. So I'm going to introduce our speakers. Our first speaker is Dr. James Burnett. Dr. Burnett is a neurologist and bioethicist at the Dartmouth Geisel School of Medicine. He was formerly the Lewis and Ruth Frank Professor of Neuroscience, and currently he is Professor of Neurology, Active Emeritus. Following graduation from Cornell University Medical College, he trained in internal medicine and neurology at the Dartmouth Hitchcock Medical Center, and he's been a Dartmouth medical faculty member since 1976. Dr. Burnett has been elected to fellowship in the American College of Physicians, the American Academy of Neurology, the American Neurological Association, and the Hastings Center. His scholarly interests are ethical and philosophical issues in neurology, particularly disorders of consciousness, the definition of death, brain death, and death determination in organ donors. He has authored over 300 journal articles and chapters on topics in neurology, neurocritical care, bioethics, and biophilosophy. In 2011, he received the Presidential Award from the American Academy of Neurology for lifetime service to American neurology, and in 2022, the Stephen E. Hyman Award for distinguished service to the field of neuroethics from the International Neuroethics Society. Our second speaker is Dr. Matthew DeCamp. Dr. DeCamp is an associate professor in the Center for Bioethics and Humanities and Division of General Internal Medicine. He's a practicing internist, health services researcher, and a philosopher. Dr. Camp employs empirical and conceptual methods to identify and solve cutting-edge problems at the interface of healthcare, policy, and bioethics. Special emphasis of his research include ethical issues and artificial intelligence, engaging patients in healthcare organizational decision-making, and global health with a focus on short-term global health ethics. He serves as a director for research ethics for the Colorado Clinical and Translational Sciences Institute, and he's a member of the Partnership of Academicians and Communities for Translation Council of the CCTSI. So this is great. These are fabulous speakers, and we can have things get started. The way the format's going to go is we're going to have Dr. Burnett speak for a while and guide us, followed by Dr. DeCamp, and then we will close out with a session of question and answer and discussion. So our first speaker is Dr. Burnett. Thank you so much for coming.
Thank you very much for that lovely introduction and for the invitation to speak today. This is a challenging topic to fully understand that involves medicine, surgery, the law, public policy, medical ethics, which all converge on normothermic regional perfusion. It's a technique to improve the success of transplanted organs after the circulatory determination of death by restoring circulation to the recently declared dead donor, while at the same time blocking off the blood flow of that donor to the brain to prevent what is known as reanimation, people waking up after they're declared dead. And it is a controversial area that some medical centers have endorsed and practiced, and others won't touch it because of ethical and legal questions. So we're going to be talking about that today. The disclosures, I have no financial disclosures, but I have a number of biases that I bring into this. And I've listed some of the organizations or groups that I've worked with and published articles with the colleagues here internationally, nationally, and through the Department of Health and Human Services, HRSA, and NIH recently, 2 years ago, co-chairing a conference there on this topic. The outline of my talk today is that I want to try to provide the conceptual foundation to understand what the ethical and legal issues are with normothermic regional perfusion. And that what is necessary for that is to establish the conceptual foundations for how death is determined both by brain and circulatory criteria. The conceptual issues in circulatory death I'll talk about are the distinction between the permanent and irreversible cessation of circulation and how this can be determined. I'm going to talk briefly about the brain criteria and mostly about the relationship between the brain criteria of death and the circulatory. And I'm going to end by promoting an idea I call the unified brain-based death determination in organ donation after the circulatory determination of death and apply how it's applied to NRP and what are the studies of its effectiveness and what are the barriers to its acceptance. So that's a lot of things. I'm going to focus on the issue of whether or not the donor is dead at the time the donation occurs with NRP, which can be construed as an ethical issue, a legal issue, a medical issue. But I'm not going to focus on other ethical issues today. My co-speaker, Dr. DeCamp, will be analyzing these, and I think our two presentations will nicely coordinate so that at the end of both, you should have a pretty good idea about these. I'm not going to be discussing the ethical issues, but I am a critic in these, and I've just listed a couple of articles here that I co-authored about those ethical problems. Well, to understand how death is determined these days in the intensive care unit, it's important to look at it from a historical perspective, and I divide it into what I might call the pre-technical era and the technology area and the technology. And around the 1950s is the dividing line. Prior to that, the medical and legal definition of death was the permanent cessation of circulation and respiration. But in determining death, physicians also examined for brain functions, namely pupillary light reflexes and consciousness, so that there were three so-called vital functions that were lost in someone who died: circulation, respiration, and brain function. And these were interdependent, meaning if one of them ceased, the others ceased rapidly. So if somebody had a primary cardiac arrest, they would soon stop breathing and their brain would be destroyed. Similarly, if it was a respiratory arrest, same thing. Or if they had primary brain damage, say a massive traumatic brain injury, they wouldn't be breathing because of damage to the brainstem. So we didn't have to think about whether someone was alive or dead who had only one or two of the vital functions and not the others. Those were impossible. Then, beginning in the 1950s, technologies supported failed respiration and circulation. CPR, first published in 1960. Everyone knows about ventricular positive pressure ventilation that arose really in the 50s, and mostly from the polio epidemic, but people had neurogenic respiratory failure. These technologies supported respiration and circulation, but they didn't support brain function. So it would be possible for someone who had a cardiac arrest and a respiratory arrest that was prolonged to suffer hypoxic ischemic damage to the entire brain irreversibly, and then be restored, their circulation and ventilation to be restored. And those people who never had any return of brain function, the question about whether they were alive or dead was ambiguous. It was not clear because they now had respiration and circulation, albeit artificially, but they had no brain function. And it was in this context that the concept of brain death became popularized. And that was in the late 1960s and early 1970s. And the idea was that if the brain is destroyed, you're dead, irrespective of whether there is mechanical support for ventilation and circulation. So these days, ICU deaths either are brain death determination or there is circulatory death determination. And both of those are permitted by law. And in most instances, the urgency to make a particular delineation of time of death is related to organ donation. It doesn't matter that much unless you're an organ donor. In circulatory death, if it's an emergency, once they stop breathing and one waits in mandatory 5 minutes, they have to have the organs removed immediately because of warm ischemic damage to them. So that knowing when the moment of death is in circulatory as an organ donor becomes very, very critical, and not so much if they aren't an organ donor. But despite the fact that this spurred intensive study of when the moment of death occurred, the conceptual foundation of whether they're dead on these grounds is independent of the instrumental value of organ donation. So there are two types of donation, and we're going to be talking about in the context of organ donation: brain determination of death, BPDD, circulatory determination of death, DCD, donation after circulatory determination of death. And the circulation in the early days, in the 1980s, it was called non-heart beating organ donation, and a little later donation of cardiac death. But it really shouldn't be cardiac death, but rather circulatory death, because that's what it is. And there are active controversies in both of these. I want to mention also the dead donor rules, since we're going to be talking about organ donation. And this is an ethical cornerstone of decreased deceased organ donation. It's not a law, but it's an ethical bedrock principle for deceased organ donation, not living organ donation, at least one of the elements. And that is that the donor must be dead before donation occurs, and that the process of retrieving the organ cannot cause the death of the donor. And these are important to keep in mind. Now, the paradigm for the controlled organ donation after the circulatory death allows the withdrawal of life-sustaining therapy of someone hopelessly brain damaged, usually, but not brain dead, in an ICU, and allows that to be done and timing it in such a way that they can serve as an organ donor if that's what the patient or their family wants. Usually they have severe brain damage, but not brain death. Family requests cessation of life-sustaining therapy to allow the patient to die according to the patient's preference, and also organ donation. And the protocol times the two so that they are together. So the surgeons are ready in the OR, scrub, gowned, the instruments are there, and just have to wait for the dead patient to be rolled in. There's also an uncontrolled form of DCDD, which is not practiced in the United States or Canada, but it is in many countries in Europe, particularly in Spain, where they have affected this. And this is a sudden, usually cardiac arrest, often outside the hospital. CPR is conducted, but is unsuccessful. The patients are dead. And then they're put on a mechanical chest compression device that provides temporary circulation, and they're returned to the hospital, they're taken to the hospital where they become an organ donor. And this is not, we do not do this, and somebody's interested in it later, we can talk about it later, but I don't want to spend too much time. What we're going to be talking today is the control, that is, the ICU patient on a ventilator. And the principal controversy when this came out was, when exactly does a patient die? What's the moment of death after the cessation of circulation? How much time must elapse? And one of the points that was brought out by critics is that if you were to restart circulation, if you were to try to resuscitate the patient, and you could do it, even though you're not going to do it, but if you could do it, then you can't say that they were dead at that time, because death is irreversible. And this became an issue, a serious issue, in the early days of DCDD. And they were said to violate the dead donor rule, and there were articles written in which they said we were killing people, and maybe you should suspend the dead donor rule, and so on. My take on this about 20 years ago was to look at how we apply the circulatory criterion of death in non-donation circumstances. And that is when circulation has stopped permanently, but not necessarily irreversibly. And parse the different definition between these two words. Irreversible means cannot be undone, irrevocable. It's an absolute and univocal idea. Permanent means continue without change. These are from the second edition of the Oxford English Dictionary. Enduring and it's equivocal and contingent. In shorthand, irreversible means it can't be reversed using current and available technology. Permanent means it will not be reversed. It will not be reversed because it will neither be will restore itself spontaneously, so-called autoresuscitation, and be started by some intervention such as CPR or ECMO. Permanence rapidly yields irreversibility, so it's somewhat inconsequential in practice. And the death determination and then controlled the DCDD, that permanence cessation is the accepted medical practice standard for the circulatory respiratory criterion. Someone dies in the hospital who's a DNR order is expected to die as on hospice, for example. Once their breathing and circulation stop, they're declared dead right then. You don't have to prove that it's irreversible. And I'll talk in a minute about how one might have to do that. It's not required. Permanence also produces incipient, rapid, and inevitable irreversibility. If you were to prove it, how would you do that? The most direct way would be to give them CPR and see if you could bring them back. But that may even be insufficient, such as the eCPR cases that people, after they've had a cardiac arrest, put on ECMO during a period of several days during which stunned myocardium recovers and their heart starts beating again. These are people who would be declared dead everywhere, but have survived because of the transition on ECMO. So that's showing that CPR fails may not itself be proof of irreversibility. Awaiting classical late signs of death, rigor mortis, dependent on avidity, takes hours. Awaiting a prolonged interval without circulation, such as over an hour, almost 10 minutes, after which everybody would agree that cessation was irreversible. These tests are unnecessary and undesirable, and determining irreversibility in our current technology era is often unachievable. Now, the medical practice standard has what I've called in an article 12 years ago, the Hastings Center report, a non-congruence between the medical practice standard requires permanent cessation and the biological standard, which is irreversibility, and that this has existed for a long time and there hasn't been any outcry. Physicians are allowed to diagnose, to determine death at this time of permanent cessation without waiting until it is utterly irreversible, which it will become spontaneously. And it's been accepted. Nick Murphy and colleagues a few years ago did a scoping review of how transplant centers use terminology. And I was personally gratified to read in their article that the majority now endorse the idea of permanent cessation, which seems to have answered the question that the critics had raised earlier about what if you could resuscitate them, and so that that's sufficient for them being dead. The time course is interesting between brain death and circulatory death. Brain death is a retrospective determination that looks at the current state after the brain damage has occurred, often hours or sometimes days early. And it's delineated as irreversible cessation, whereas circulatory death is a prospective, real-time determination of things that are happening right now. And 5 minutes of completely cessation is long enough without to exceed the interval during which autoresuscitation can occur. And it's delineated as the permanent circulatory cessation. Is it necessary to change brain death to a prospective determination? I don't think so. The World Brain Death Project published I was one of the signatories, article in 2020. The majority of the editors the authors of this thought that it was fine, and I didn't oppose it, even though I think it makes more sense to maintain it as irreversible. And the American Academy of Neurology has recently done the same thing. But the American College of Physicians, in a recent paper, said they thought that brain death should be maintained as irreversible, which is more suitable for a retrospective determination. And I think that it's useful because by using that term, it requires the exclusion of all reversible contributory factors such as hypothermia, hyponatremia, hypoglycemia, or any other metabolic or toxic factor. It has to exclude those. I mentioned autoresuscitation, and I want to just make a point that autoresuscitation in controlled DCDD does not occur after 5 minutes, but it does occur in uncontrolled. And there are physiological reasons for that we don't need to go into now. But the time interval, a 5-minute interval after the complete cessation of circulation, is sufficient to exclude autoresuscitation. And it probably would take 10 minutes for uncontrolled. So at 5 minutes after mechanical asystole, it doesn't have to be electrical asystole, because sometimes there are idioventricular rhythms, there are various things that don't generate a heart. Pulseless electrical activity is perfectly okay for mechanical asystole, because the issue is circulation, not whether the heart has some electrical function. And CPR will not be performed, autoresuscitation will not occur. And we must prove total loss and permanence using some technology, not just palpating a pulse, looking at things like intra-arterial pressure monitoring, which is very simple, and as almost everybody in ICUs have one of those. Or in emergency rooms, sometimes we use a portable echocardiogram looking for opening and closing of the aortic valve, which is quite sensitive for any flow. Let me just talk about brain death for a few moments, only because we're going to come back to the brain-based concept of death. This, of course, is the irreversible cessation of all the brain's clinical functions, and it constitutes human death. It's misleading, but standard terms, part of our lexicon. Now, there's widespread acceptance by physician and society, though some persisting confusion on surveys, both of medical and nursing personnel as well as the public. My experience is it's accepted better by doctors than it is by the families of patients, which is the opposite of circulatory death, which is accepted better by the families of patients than by doctors. Because in brain death, the doctors know why that is criterion of death, but the patients don't look dead, the families. Whereas in circulatory death, as soon as the heart stops, the families realize they're dead, even though the doctors know that they're not quite yet ready to be determined dead. There's still opponents to this, mostly for conceptual and religious reasons. Internationally, it's law throughout much of the developed and much of the developing, practiced in more than 90 countries by the World Brain Death Project's studies. And I have at the bottom here the citation from the overall paper, very long paper in JAMA, it's on 20 pages, which is a long JAMA article, but most of the data were not in that article, but in the 17 appendices, which you can open from that article that are electronic format only. And the ones that I wrote on the conceptual and religious stuff are that way. There are different differences in some of the criteria for brain death among different countries, but it's well accepted. And brain death is human death because of the cessation of functioning of the organism as a whole and the loss of the critical emergent functions. And I and others, and my colleague Andrew Wong, who with me wrote this article in the Journal of Medicine Philosophy years ago, we basically point out that the parts of the organisms remain alive with technological support, but not the organism as a whole. and that applying the field of mereology, which is the mathematical and philosophical study of a whole entity and its parts, or among its parts, their relationship, explains the brain death paradox, that the body parts can be alive, but the whole, which is greater than the sum of its parts, the organism as a whole is not. And that this is a criterion of death, and circulatory cessation causes it when the brain has permanently lost function, which is relevant for the circulatory determination of death. And the brain is sui generis among organs. It cannot be recreated by technology. It can't be functionally transplanted. Its most ineffable property, conscious awareness, is far from being understood and may never be. Other organs maintain brain health to permit continued functioning of the organism as a whole. And now the legal debt, let's switch to the law and how the criteria are related to each other. Most states, including Michigan, their death statute is either the Uniform Determination of Death Act, as I have here, or a very close rendition of it. An individual who has sustained either 1, irreversible cessation of circulatory and respiratory function, or 2, irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A termination of death must be made in accordance with medical standards. This UDDA was formulated by the AMA, the American Bar Association, the Uniform Law Commission, and the U.S. President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research in 1980, and then published in the President's Commission's first book of the 10 that they published in the early 80s, called Defining Death. What it doesn't do, either in the statute or in the book, is clarify the relationship between the brain and circulatory criteria. They seem to be independent. And I would argue that, at least in the context of circulatory death determination, they are contingent. A circulatory criterion is contingent in the brain frame. That is, the circulatory criteria only becomes valid once the brain has been destroyed by hypoxic ischemic damage from lack of circulation to the brain. And if the person is resuscitated when the brain is still functioning, then they're not dead. But if they're resuscitated, your heart is resuscitated after the brain is gone, they're still dead, just that they're brain dead, which is the brain criteria. The problem is that many of these death statutes based on the UDDA offer dual, seemingly equivalent criteria without explaining their relationship, and particularly in this context, their contingent nature. And that faulty design has led to confusion over things like NRP, which is clarified by using the brain-based death determination concept. So finally, with all of that background, and I'm sorry to have to spend so much time on that, but you really can't understand this without that background. NRP, where after death is determined, the ECMO circuit restores circulation, but brain circulation is attempted to be occluded by clamping the brachiocephalic arteries of the aortic arch that go to the brain, which includes the major circulation of the brain through both the common carotid arteries and vertebral arteries. Some surgeons also sever the distal ends of the clamps so that blood in the brain drains out. We'll come back to that in a moment. In heart donation, the heart may be started again in the donor in situ by electrical defibrillation. And there's continued perfusion of organs similar to transplant, produces some success rates similar to brain death termination. So how would we determine death in the person who's on NRP after DCD? Well, the donor is it's a form of DCDD, and that requires that 5 minutes of complete circulatory cessation to assure that it has ceased permanently. That autosuscitation will not occur, but no medical attempts are made to restart circulation. But wait a minute, now we're restarting circulation. Not only are we restarting it, but it was planned to restart it. So that means circulation didn't cease permanently because we just restarted it. So that would seemingly invalidate the basis for death determination in the donor. So starting it retroactively invalidates the preceding death determination predicated on the permanent cessation of circulation. So conceptual confusion raised by NRP includes things the American College of Physicians, and I know Dr. DeCamp's going to be talking about that, criticized TANRP as thoracal dominant, as far as the abbreviations, protocols, and they said it represented organ retrieval after cardiopulmonary arrest and the induction of brain death. That is, by clamping the arteries that go to the brain to deprive brain of blood flow, that's inducing brain death. And they further implied in their statement that the mechanics confounded brain death and circulatory death, and that the determination seemed to begin as a circulatory determination and ended as a brain death determination. Well, the unified brain-based death concept, in my way of thinking, can clarify this only in the setting of circulatory death, primary circulatory death. It causally and temporally links the cessation of systemic circulation to the cessation of brain function after intractable cardiac arrest by the following inevitable physiological cascade. Permanent cessation of systemic circulation, which occurs after complete cardiac arrest, leads to permanent cessation of brain circulation, which leads to permanent cessation of brain perfusion, which leads to permanent cessation of brain function. That means that permanent systemic circulatory cessation always produces permanent cessation of brain function if there is no brain perfusion. But the problem is, as I said, that it would perfuse the brain. So NRP clamps off the arteries that perfuse the brain, or at least the principal ones. And if it succeeded in completely blocking all brain circulation, excluding the brain from the ECMO perfusion circuit, that it would perfuse the thorax and the abdomen, but not the brain, then the same cascade that I just outlined would remain uninterrupted. So that it requires zero brain circulation for this to be true. And that if that is there, at least in my way of thinking, it would be unnecessary to directly measure brain function, which is very difficult to do after permanent cessation of brain circulation, and difficult. It's impossible to establish permanent cessation unless there's cessation of brain circulation. But does it completely block all brain blood flow? One might think, sure, if you're blocking off all the arteries to the brain, how's the brain going to get blood? Well, there's a parallel system of collateral circulation that perfuses the brain. And I'll show a picture in a moment of those collaterals up the anterior spinal artery and other sources. And normally they comprise an inconsequential component of brain circulation. But when the major arteries are blocked, which is part of the NRP protocol, brain autoregulatory autonomic reflexes kick in, dilating those collaterals to try to get some blood. It's a reflex. And then suddenly they create perfusion. So surgeons must prove that whatever they do completely blocks brain circulation and NRP, because any residual brain circulation may restore some brain function. And this is the picture that Alex Manera and colleagues published in the American Journal of Transplantation in 2020, looking at that system. We don't have time to go through those. Sorry, I don't want to take up more time than I already did. But just to point out that these exist, and they become activated when you clamp up the main blood vessels. So what do studies of this show? They show that it may not completely block off brain circulation because of collaterals. So that as a result, at the University of Cambridge, the Royal Papworth Hospital in England, the surgeons sever the rostral ends of the clamp arteries, that is, the part attached to the brain, and allow the blood to drain out of the brain. So if any collateral blood ends up there, it completely goes out through those severed vessels, which it wouldn't do but for severing them. And preliminary studies in a few patients using this technique show measuring intra-arterial pressure at the surface of Willis, the base of the brain, that the pressure is non-pulsatile and it has a baseline that is the same as the diastolic pressure during complete cardiac arrest. So I think that's fairly persuasive. There have been other studies of this, 3 animal experiments showing that in 2 human cases from NYU, disappearance of previously recorded brain pulsation by transcranial Doppler ultrasound, accompanied by clinical signs of apnea, unresponsive synapsing brainstem reflexes. But the precise threshold for brain blood flow leading to completely absent brain function remains unknown, and some slight blood flow to the brainstem may be enough to maintain some of the phylogenetically old neurons in the brainstem, which are not as metabolically active as the newer neurons in the neocortex and the thalamus, because they're metabolically less active. There was one other study that was just published 2 weeks ago. It actually hasn't been published yet, but a preprint is available from the American Journal of Transplantation, where they did scintigraphy of blood flow in these cases after this type of procedure was severing the arteries, and there was no evidence of any uptake. So this unified brain-based determination that I am favoring has been accepted by a couple of international collectives, and I was involved with both of them, and the Canadian Clinical Practice Guideline on definition and criterion that I wasn't part of directly, and I listed some of those references here. The barriers to accepting this are conceptual disagreement over the definition and criterion of death, disagreement over the validity of interpreting irreversible as permanent, ethical controversies, whether the clamping itself causes death, which was a concern, and Dr. DeCamp pointed out to me in a paper that I first authored from 11 years ago. I had raised this as an issue that, and I had forgotten I mentioned it back then, and legal issues that are paramount, really, with the UDDA, that they have dual criteria of death. Mine is a single brain criterion. So it's inconsistent with the UDDA. The UDDA requires cessation of circulation, not just brain circulation. So it wouldn't work in the USA to have this death. And then the question about arterial clamping. Finally, summarizing, systemic ECMO on the DCD donor invalidates prior death determination because it's not permanent. But if the brain circulation is excluded from the ECMO perfusion circuit, the donor is dead by this concept because the cascade is uninterrupted. But surgeons must prove, who do this, that there's zero brain circulation. Well, it's up to them. And at this point in time, most surgeons in the United States who do this do not do the severing of his vessel. They just do the clamping. So they don't prove that there's zero brain circulation. And that means that there is a serious problem. And I thank you all very much.
Thank you for this tremendous opportunity. It's a real honor and pleasure to be here. I'm grateful for the invitation this evening and for all of you to attend and spend time with us talking about this difficult topic. It's tough to follow Dr. Burnett. I've been a long admirer of his work, and he brought so much clarity in thinking to this field. And so this is a tough act for me to follow. But I hope that over the next 30 minutes or so, we can perhaps recapitulate some of these themes and then dig deeper into some of the ethics concepts that affect this debate over NRP. This is a tough subject matter. I think when I first got involved with this, I needed to read this literature multiple times to even really understand what NRP was. Also, there's a lot of disagreement about this topic. So even as I present ethics issues, I certainly invite disagreement with the way I interpret them, but I do at least hope to get us toward some ethical clarity when we use some of the ethics concepts and discuss some of the ethics around NRP, and perhaps the Q&A will allow us to do some of that as well. These are my disclosures. I don't have any financial conflicts of interest to disclose. I am a consultant to the American College of Physicians on various ethics policy issues. I do want to emphasize that except where policy is explicitly referenced, the views I present tonight are my own, not those of the American College of Physicians or anyone else for that matter. Start with a bit of a summary of where we are and how we got to this point. I think it's important to remember that there's a persistent problem of organ supply and organ donation in this country. We're both supporters of organ donation, and I consider tragedy when a life is lost awaiting a needed organ. You can see some of these statistics here, which don't even tell the full personal story of what it means when someone needs an organ and one is not available. That is a real tragedy. We've already talked about that there are two different types of donation. There's donation after a brain determination of death, and there's donation after circulatory death. Since 2002, around the world, and in this data you can see in the United Kingdom, there's actually been a tenfold increase in the number of donors that get to donation through circulatory determination of death. So in other words, linking back to those statistics, DCD has become one way to help us solve the terrible tragedy of the shortage of transplantable organs. Why is this? Well, I think there are some complex reasons around why we're moving toward DCD in general, but it's really interesting that historically, actually, the first heart transplant was via DCD back in 1967. So in some way, moving toward DCD now is a little bit like moving back to where we started in organ transplantation. So it's not exactly new. A second point that's important is that although these organs have been considered in the past to be inferior due to the damage that occurs during that 2 to 5 minute hands-off period, this paradigm has recently been shifting, and it shifts even more when we go toward the idea of NRP. Some estimates suggest that use of DCD donors could increase the cardiac donor pool by 10, 25, even 30%. So you can see the appeal for DCD as a means of organ donation. There's a lot of excitement over what I'm going to talk about in this next step, which is NRP DCD. These are a few papers that tout normothermic regional perfusion as the next frontier in organ transplantation. UNOS excited about this new technique. And it's even a technique that, by the way, if you don't understand it from what I present in just a few moments, you can go on the internet and see videos of exactly how a donor is attached to the NRP technologies and really just how fast it can be done, how fast it happens. These videos are freely available. But yet there is ethical disagreement over NRP alongside DCD. The American Society of Transplantation in the top left supports NRP. The Ethics Committee of the Organ Procurement and Transplantation Network says that NRP should proceed, but with caution. And then as we've already mentioned, or has already been hinted at, the American College of Physicians in 2021 wrote a pretty strong statement expressing concern and opposing NRP. So evidence of disagreement in this complicated space. Why is it appealing? Well, I think to go back and just highlight some of what we've already said, these persistent shortages in organ supply, NRP could be proposed for use in the U.S. Evidence is sparse, and proponents do claim that NRP can increase that quantity and the quality of organs, particularly for those organs that are very susceptible to that warm ischemic time, that 2 to 5 minutes, hearts, intestines, and so on. And they also allow in vivo assessment of organ function. NRP has actually already been used for several years in other countries, notably Spain. So this is a practice that has been used elsewhere, and naturally we look to other countries and suggest that, well, perhaps we should use it too. So there is a precedent elsewhere for it, although importantly, in some of those other countries, they have different laws and social policies around the determination of death. And already NRP protocols exist. We've known about them for a while. There are different institutions around the country, sometimes under research protocols, other times under surgical innovation protocols. Keep that in mind, because we'll come back to that when I ask some questions toward the end about who should be responsible for the ethics review of a new technology like this one. What is NRP? So now we're going to dig deeper, and I'm going to try to help us understand exactly what NRP involves. In short, after a cardiac arrest, NRP uses bypass or ECMO, other technologies, to recirculate the patient's own blood at or near body temperature, allowing the heart to restart and to resume cardiorespiratory functions. And you can see on this slide just a couple pictures that show what this machinery looks like in schematic form. This is NRP. Here's a different way of looking at NRP. This is a figure from one of the surgical papers about NRP, and it sort of shows you what happens. Donor transport to the hospital, withdrawal of life-sustaining therapies, hypoxemic cardiac arrest, followed by circulatory arrest. Then there's that 5-minute hands-off period, which has already been referenced. Circulatory death is determined at that moment. And then the following happens: ligating the arch vessels, cardiopulmonary bypass, reintubation, resuscitation, and now we move into the organ procurement protocol. So that's sort of what happens. I put question marks here because we'll talk about what this determination of death means and what those actions mean in follow-up in the procedure of NRP. This table just shows you some of the differences between NRP and one of the competing technologies that's out there, which are ex vivo organ-in-a-box type perfusion devices, where instead of restarting in the body, you might take a heart, put it into a ex vivo perfusion box, and perfuse it that way. Key differences. NRP allows that in vivo assessment of organ function after the heart resumes beating. In other words, once that cardiopulmonary resuscitation, once the functions are restarted, now we can take an echo and we can look at the heart. How well is it functioning? We can do lab work for the liver. Is it regaining its function? We can allow those kinds of assessments that may be more limited on the right in the case of the ex vivo devices and boxes. One of the questions I had about NRP when I first learned about it was, how long does this go on when someone is attached to this circuit in the NRP procedure? Is this minutes, hours, days? Because that seemed to matter to me from an ethics perspective. Generally speaking, the donor is on NRP for about 60 minutes at a time. This isn't something where they're spending protracted amounts of time on the NRP circuit. So that's a key difference compared to ex vivo perfusion, where these ex vivo devices can actually be used to perfuse the organ for hours on end. Really importantly, on this lower left, NRP is thought to uniquely have the ability to reverse the warm ischemic damage in a more physiologic state than organ in a box or than standard transplantation would be. Now, some have suggested, you might say, well, which is better? Shouldn't we just figure out which is better between the organ in a box, ex vivo devices, and NRP? It turns out to be challenging to conduct those head-to-head studies. And so some people have been concerned that head-to-head studies may be limited due to the fact that the two methods will almost invariably occur in different time, different circumstances, different ways, which makes comparing them head-to-head quite a challenge, limiting us in our ability to answer a question based only on the facts, which I think pushes us more toward thinking more deeply about, well, what are the ethics? So what is the ethical debate over NRP? I think it's critical to remember the three ways in which NRP diverges from usual DCD donation and organ retrieval. Instead of cold perfusate and a near immediate explantation, NRP recirculates a patient's own blood at or near body temperature, allowing the heart to restart. That's a key difference. Recognizing that recirculation could result in recirculation to the brain, in the case of NRP, physicians must take actions, such as that ligation we've already heard about, to prevent that reperfusion from occurring. And as a result, recirculation, in my view, recirculation is deemed regional, but only because those active steps were taken. So that's the R in the NRP, regional because of active steps. Now, there are a couple questions, a couple preliminaries that I think could make our debate easier if it were the case. If NRP is not better than traditional direct procurement, then it might circumvent this ethical debate altogether, right? If NRP were worse, we wouldn't be talking about this. Now, the evidence here, I would say, is mixed. There's evidence in improving outcomes for preventing cholangiopathy and liver transplant and earlier return of renal function in kidney transplant. But a small study showed no difference in NRP versus direct procurement in heart. So some disagreement, some uncertainty in the literature. The evidence is not going to get us out of this ethics debate. In fact, some surgeons, however, and some people, I would say, patients, families, and society, believe the evidence so much so that I show you this image from a survey taken at the Alliance Forum. And it says, do you believe there are health advantages for the recipient of an organ recovered using NRP? And overwhelmingly, the answer here is yes, so much so that actually some people are now talking that it's not just that NRP is ethically permissible, it's actually obligatory. Some people believe the evidence is so much in favor of NRP improving outcomes that we moved from whether it's just permissible to now it's obligatory, that if I were to get an organ, it should come from NRP. You might also ask, does NRP cost less? Cost is obviously not the only factor or the most important factor that concerns us from the standpoint of an ethics debate, but it might help us in our decision-making. In this slide, I created an image that just shows you that, in fact, NRP probably is less expensive on average than ex vivo devices, those in-a-box devices. But others might point out that, well, that's a minor increase in cost for what's already a very expensive endeavor, right? We're pushing above $1.4 million and a slight increase in cost for ex vivo. Different people are going to have different opinions about the relevance of that cost amount. So let's go through some of these ethics issues in NRP, and this one I'll be quick about because we've already talked about it some this evening. By restarting circulation, NRP appears to reverse the very condition upon which the declaration of death was made. In other words, at this point in our process, when we have circulatory death, the actions that follow render that initial death declaration invalid. As a matter of fact, the donor is resuscitated, and in fact, in the procedure, you can even see that number 4 uses the word resuscitation as part of the procedure. And declaring death alone, in the matter of declaring circulatory death, does not make it so. And I want to highlight that for a second, because there can be confusion about this. Some people you'll hear talk about NRP, and they'll say, well, they've already been declared dead, so they're dead. And what follows can follow. From a legal philosophical perspective, from an ethics perspective, the issue at stake there is whether the determination of death is what's known as a speech act. Legal philosopher John Austin talked about speech acts and described them as doing something by saying something. Classic examples of this in ethics are things like, I promise, I apologize. When I say that, that's an action. That's a speech action. And so the question would follow, is the determination of death really like that? Is it the fact that because death has been declared that makes it so? I would suggest that although physicians and other clinicians have the authority to determine and declare death, it is not their saying it that makes it so. They're saying it as a reflection of the biological reality that they're observing. It's not their saying it that makes it so. Getting this determination right, I think, is really important because of the fragile nature of trust, of public trust in the organ donation and transplantation enterprise. Trust that's often fragile, and fragile among certain communities more so than others. It doesn't help to see stories like these just within the past year, either on national public radio or in the New York Times, where there have been concerns raised about how a determination of death was made in Kentucky, or concerns about how organ procurement organizations are operating along their waiting lists, perhaps skipping down the list in ways that some people find inappropriate. When stories like these come out, trust can be broken with the public, and that can, in the end, in the longer run, right, reduce organ donation rates, causing us more of the problem that we're trying to solve. Sometimes this is really complicated to think about, and how do we feel about, how do we react to something like NRP? I sometimes pause and just ask you to engage in this thought experiment. Imagine yourself to be an outside observer of an effort like this one. What do you make of the thought that the very same behaviors and actions under one scenario are life-saving resuscitation of a patient, and another is proceeding to organ explantation? It's hard to get your head around that, but it's an important centering thought experiment, I think, when we consider the ethics of this procedure. All right, let's move to issue number 2, intent. This comes up a lot as well in the ethical debate around NRP. For some, the distinguishing characteristic of NRP is about intent. In NRP, the intent is not to resuscitate the patient, but instead to preserve the organ. So the intent is different, and that changes the way we think about the ethics of this. Oftentimes, people who bring up intent will appeal to the doctrine of double effect, and this is an ethical doctrine, some would say, that allows something bad to happen. It's okay for something bad to happen so long as the evil is not intended as an end or a means, and the foreseen evil is not out of proportion with the good. The question we wrestle with ethically is, does NRP meet this standard in the doctrine of double effect? And here again, I would suggest no. Setting aside the UDDA, that determination of death we were discussing previously, and was discussed by Dr. Burnett, does not say anything about intent. That's not in the law. But here it seems that the means really is intended. The death of the patient is the means, and without it, transplant could not occur. Issue 3, the active steps that are needed to prevent perfusion. You can see the ligations in the top of this figure. In the literature, various explanations come about as to why it's exactly necessary to ligate the cerebral vessels. I've seen this change over time when I read the literature. Sometimes I hear that it's to prevent cerebral reperfusion and any possibility of reawakening the brain. I've heard that as the rationale, but it's not the only rationale. It could be to allow a natural progression to death. Some would say it's to maintain a state of death, and others have simply said that it's to be more efficient in the use of the ECMO or the bypass circuit. It would be inefficient to allow blood to perfuse up to the brain, when at this moment all we're concerned about is the heart, the lungs, and the other internal organs. I think these rationales are complicated, and I think it's difficult to reconcile the prevention of cerebral recirculation with the dead donor rule that we've already talked about, and the actions that are necessary to ensure it. stating that doing so allows natural progression to complete cessation of brain function, acknowledges that brain death has not yet occurred, and mischaracterizes the actions, I would say in this case, as allowing a natural progression. Doesn't seem natural. We have to really spell out what we mean by natural. The second rationale says that our protocol ensures our commitment to respecting the discrete boundary of death. And third, this rationale says after starting NRP, standard donation after brain death will commence. And this is what Dr. Burnett referenced earlier, where the goalpost has shifted. We started in the circulatory, cardiorespiratory death criteria, and then at this moment, when we take active steps, we move to the brain death criteria. We've shifted the goalposts. What's really important about those last steps, and this may be a place where we differ, is under these time frames that I've described, determination of brain death could not have occurred. This is inconsistent with our medical standards for determining brain death. So if we switch from DCD at this moment to DBD, it's an unfair switch because we couldn't possibly have made a determination of brain death. It's really important, I think, to acknowledge that in this case, not ligating may not be an option. Not engaging in this may not be an option. This is from an animal study. And what it shows on the left versus the right is that if the aortic arch vessels were not clamped, cortical electrical activity resumed. This is an animal study replicating NRP in pigs. Now, all of us will acknowledge that we don't know what EEG signals really mean. Evoked potentials, we're not sure what they mean, but this study would at least cause concern for us to suggest that not ligating these vessels is not an option. I do highlight and say again what Dr. Burnett said. These are not particularly new concerns. If you look closely at this reference at the bottom right, the first author is James Burnett. Some of these concerns were voiced back in 2014. And from an ethics perspective, it's hard to see how some of the fundamental ethics arguments have changed since that time. We have to be careful of another shift we sometimes make in talking about this procedure from the standpoint of ethics. At times, you'll hear people say that the amount of neurological function that's present or that could be in existence based on that bar graph I showed you is not meaningful. This represents an ethics shift to me. It shifts us from a debate that's about determination of death to one that's about a value judgment of quality of life. That's a shift. It's an unfair shift in the way we think ethically if we move from determination of death to a perhaps hidden value judgment about what counts as a meaningful life. I think it's just important to get that out on the surface and acknowledge it. Issue 4, transparency and consent. This is another survey from the Alliance where they asked should the use of NRP protocols in the recovery of organs be disclosed to the donor family. What about the role of consent in this? You can see quite a lot of differences of opinion in this chart. 31% say full disclosure should be provided. Number of people are unsure. Some people say limited information. And some people even say no. Authorization for donation includes authorization for any recovery method. So questions about the role of transparency and consent. Here I would suggest that consent is important. It's necessary for this process, but it's not sufficient. Transparency about the details of NRP, I think, is prerequisite to trust and informed consent, keeping that public trust in the organ donation enterprise. And while I think there could be disagreement about how much information to provide exactly to patients and families and when, the default should be in favor of disclosure. It's not that people have a right not to know that this is what happens in the organ donation procedure. And that NRP may be consistent with the donor's wishes. In other words, the wishes to become an organ donor and to donate one's organs. That's actually irrelevant to whether the patient is deceased under U.S. law, under that Universal Determination of Death Act, Uniform Determination of Death Act. In other words, even as we laud patients' wishes to be donors, and we do and we should, consent alone does not confer the full ethical legitimacy on NRP. It's not because people said it's okay or that they're okay with it that makes it okay, especially when this wish can be fulfilled by other means. This is not the only way of donation. There are alternatives. And by analogy, patients we know can't consent to medically contraindicated procedures. So consent alone is not going to be enough to carry the ethics argument, particularly when there are ethical alternatives. As I've already hinted at, NRP is not the only way to help improve organ donation and to fulfill donors' wishes. We have ex vivo devices that can perfuse organs outside the body, and that's an ethical alternative. I want to close with a couple comments that are really more questions in nature, just to get us thinking about other ethics issues that go alongside this complicated debate around NRP. One is, should we consider that UDDA? Maybe the problem is that we have the wrong standards, legal standards, for the way we think about death, and this has come about from time to time, where the Uniform Law Commission considers revisions to the UDDA, changing irreversible to permanent in the language, or specifying in a lot of detail the criteria that should be used for neurological determination of death. This might be one way out of our quandary, but it's not very promising for NRP, because I would suggest that whether or not we're using words like permanence or irreversible, that doesn't apply to NRP. Because when NRP occurs, cardiorespiratory functions could and did resume. It doesn't matter whether we call them permanent or irreversible. And we've already heard from Dr. Burnett about concerns around the use of permanence for determination of death by neurologic criteria. I won't talk about that. What is the role of NRP in the transplant system more broadly? Responding to scathing reports of 25,000 wasted organs per year in the U.S. system, there are plenty of efforts that are afoot at the policy level to help with that shortage problem, to improve the organ donation system, including around issues of equity, put more quality metrics in place for additional accountability for organ donation and organ transplantation. On the ground, some of the things we hear is that such efforts are putting additional pressure on organ procurement organizations that could have unintended consequences, such as affecting our judgment about the risks and benefits of NRP itself. These external pressures can certainly influence the way we think about decisions, for better or for worse. What about justice as fairness? There's been some discussion that whatever we think about those risks and benefits of NRP, they may be borne disproportionately on some people over others, and that's an issue of justice or a potential unfairness. Some have suggested, in fact, that drug overdose victims may be preferentially good candidates for NRP. And what do we think about that as a society from the standpoint of justice when the burden of organ donation falls on some of us over others? Again, a question. Question 4, should you accept NRP organs? If you're on the side of questioning or having concern about NRP as an institution, if you disagree with NRP, should you accept NRP-derived organs, or is that a state of moral complicity with a practice that you find unethical? Here, one of the main challenges is actually knowing whether or not an organ came via NRP. And this is just an illustration of that challenge, where researchers had to, in order to do research comparing outcomes, had to develop a new way of identifying NRP-derived organs. The key determinant being death to cross-clamp time, because individuals on NRP spend more time in that period compared to usual organ donation procedures. So determining when an organ came from NRP would be a first step if you're concerned about the idea of accepting these organs. Question 5, what about abdominal-only NRP? We've been assuming one type of NRP for the purposes of this discussion, the thoraco-abdominal version, which includes the heart and lungs, which restarts cardiorespiratory functions, which is the reason why we have concerns about the determination of death by those criteria and reversing it. But what if You simply limited ECMO to the area below the thorax. And now you're perfusing the liver, you're perfusing the small intestine. Those organs could be used. Tough question. I think it presses here more on the idea of what is the moral importance of perfusing something inside versus outside the body? Where would we draw the line ethically? Question 6, I hinted at this before when I said that sometimes this occurs under innovation and sometimes this is occurring under research protocols. Who should review NRP? In one published report from UCSD, review was both by the Hospital Ethics Committee and the IRB. Obviously, if this is done under research ethics and research regulations come into play. The IRB will be involved in questions about consent and who is a research participant. Is it just the recipient of the NRP organ? Is it the donor, the donor's family? Is it both? How do we define research participant in that case? Clear implications for the way we think about regulating and governing the use of NRP. So just to conclude with a couple final comments, I do think the thoraco-abdominal version of NRP raises ethics questions that are not answered solely by reference to intent or consent. And I hope we've got some more clarity about some of the other ethics concepts that impact this decision. Although some ethical questions raised by NRP can be studied empirically, like what's the effect on public trust? How do outcomes compare from one methodology versus the other? Others a lot more fundamentally conceptual or ethical, such as that determination of death itself. And lastly, just to say again, the current policy environment may be placing external pressures on the use of NRP. Thanks for your time.
Is NRP currently practiced in Grand Rapids?
Is NRP, the question was, is NRP currently?
NRP practice in Grand Rapids. Maybe our speakers aren't prepared to answer that, but
Yeah. And I can say that at our institution, it's not. There are other centers that perform NRP.
thank you.
And I just to add to that, you mentioned this as well. I mean, different institutions, different states are coming to different decisions about this procedure. Sometimes institutions that are across the street from each other have different policies about the use of NRP. So there's a lot of heterogeneity around policies. And do you want to comment?
Yeah, a good example in Boston, you have the Mass General Hospital and the Brigham and Women's Hospital that are even merged, sort of, and both important teaching hospital and Harvard Medical School. The Brigham and Women's has an NRP program. The surgeons at MGH won't touch it.
This is maybe a question more for Dr. DeCamp. Do you know, we looked at Spain saying how they were they're using NRP and organs from those types of donors. But do you know, was NRP less controversial for that country? And if it wasn't as controversial as it is here, does the fact that that country has an opt-out system for organ donation, whereas we have opt-in, so does that country more trusting of the organ donation, environment than what we are here in the U.S.?
No, great question. I'm sure you have comments you can make on this too. Certainly, what your question makes me think about is that the NRP issue really can't be taken in isolation, right? That whatever decision or how we think about it, it has to be sensitive to the unique social and cultural context of where we are, whether that's legal definitions of death, whether it's social norms around organ donation, whether it's the type of opt-in, opt-out that we have for organ donation. So I think that whole context does matter. It probably does make a difference in the way different countries, think about this.
A good example is Spain, that has an opt-out that has everyone in Spain is an organ donor unless they opt out. And they have published a lot of the data that I was showing about NRP. Their DCD is amazing. And when it was attempted in the United States, there was an excellent protocol that was done in New York City under an NIH grant and protocol that was looking at, is uncontrolled DCDD going to work in the United States? And they had this van, and if someone had a cardiac arrest on the street, they would be contacted and they would go there, and there was resuscitation, and they would be put on the thumper thing that would compress the chest. And what happened was they couldn't get a single case. In 2 years or so, this was done. And the entire problem was consent. Because when it's uncontrolled, someone drops dead on the street, who's their next of kin? How are you going to talk to them to get consent? It was impossible. So, yeah, certainly the system, a legal system of opt-in versus opt-out is very, very important. Where in Spain, it isn't an issue because they're in. And so, yeah, that's and it's been looked at by health economists in this country, saying that we would never be able to have the same opt-out system that they have in Spain because we don't have a nationalized system. There's no opportunity for all of our citizens to opt out. You got 20% or so of the population that never sees doctors, and you're excluded from the healthcare system. So that it just wouldn't be possible.
Is it?
And I may just comment briefly, if you would allow. I know within the heart-lung transplant community, NRP was more rapidly adopted in Europe, and many feel that that was because of cost barriers and a significant decline in hospitals willing to support patients until brain death could be determined. And so there was felt to be a necessity, as there has been a dearth of available donor organs, and even donor ages started rising. And so there was a lot more pressure throughout Europe, and they clearly adopted NRP years ahead of any thought in the U.S. I think we had other questions over here.
First of all, gentlemen, thank you very much for your time tonight. My question has to do with the issue overall. Is it handled differently at a pediatric level, or is it pretty simple across? Well, not really a simple issue, obviously, but is it pretty consistent across the board?
Yeah, good question. In my view, the philosophical, ethical issues are largely analogous, if not the same. I think that what may be different, back to the other question we had, is that the context of pediatric transplantation is different. There have been some more recent controversies around pediatric heart transplantation that may cause institutions to not want to go down this path, not because they think NRP is fundamentally wrong or inappropriate for that setting, but more because they're thinking about the overall institutional risk and environment because of some of the controversies that have happened in peds transplantation.
One of the ethics journals recently just had a symposium on this question about pediatric organ donation, and many of the issues aren't unique, but they're different in a way. And the consent, and so yeah, my practice didn't include any pediatrics, so I don't have a lot of personal experience with it, but it certainly has been studied. Did you see this? I think it's the Journal of Clinical Ethics.
JCE, I think.
Yeah.
I think we have another question there.
So, do you think that if healthcare was more accessible for people in the United States, that a better system would be like the Spain system where you can opt out instead of like here, whereas you would go to like the DMV or the Secretary of State and they put like the little heart on your license to show that you're a donor, is a better option than, like opting out or opting in?
Well, it's sick. I think the opt-out system, that the reason that I just cited about the fact that we don't have a nationalized health system is only one reason that wouldn't work. Another reason is that we have, as part of our tradition, this very libertarian concept of personal liberties that is greater than in some other countries. And I think that this idea that there would be an automatic use of someone as an organ donor would be resisted mightily by a significant segment of the population, even if there were a nationalized system or some mechanism to assure that everyone was offered the opportunity to opt out. It's just in our DNA, our traditions, that we don't like that phenotype.
It's hard not to see that. Well, we didn't talk a lot in either of our presentations. Maybe I hinted at issues of justice or fairness, but we didn't talk much about the disparities that exist both in organ donation rates and in organ transplantation rates in our country that affect racial or ethnic groups to different degrees, socioeconomic status to different degrees. I do wonder about your question. If we had a more equitable health system, would we have less overall mistrust and then therefore potentially have greater rates of people willing to be organ donors, which then means we don't have such a shortage of donors, which means that we don't then have to turn to controversial technologies to solve the shortage that we're trying to fix, particularly for certain groups. Again, I think another reflection of all these pieces of the puzzle that work together.
While we're getting another question, I'm going to throw one out to you also. One of the issues that we've talked some about before internally is the concepts of autonomy and beneficence. And so in areas of infusion, what role does the potential donor's autonomy, especially if they had an express wish to be a donor, and then those of us that work in the transplant world know this concept of benefit to the potential donor families, and to the point even of having people begging you or talking about the incredible rewards they had from, at least in the middle of tragedy, knowing that their loved one was a donor. And so does that impact at all on this NRP decision, those two concepts?
Yeah, I think they do. And I maybe hinted at them in this idea that I think consent or the donor's wishes are important and to be valued. And it's no doubt we have to acknowledge the benefits that come from transplantation too, the benefits to others. And I think that we should praise people who have made the choice to donate. Maybe to me, it's a little bit of a question of drawing the line, where we draw the line, right? In that we know we're going to draw the line somewhere, particularly when it comes to the dead donor rule. And how close do we want to get to it? A different argument that you hear about in ethics that I didn't talk about this evening is the slippery slope argument. The idea that, well, once we make this step and it's getting closer to that line, the next step to the line is a little easier, and then the next step is a little easier. So to some extent, it could be a question about line drawing. Another ethics concept that I would suggest is important that I didn't talk about this evening is the idea of humility. Humility is an important ethics concept, and I think we have to have my view is that I think we have to have a lot of humility around the determination of death, which is one of the most solemn acts that a physician or a clinician does. And I think humility should affect the way we move that needle. I don't know. What do you think?
Yeah. The arguments have been made taking your argument a little further that if the most relevant factor is fulfilling the wishes of the donor, and why do we need a dead donor rule? And some people have written eloquently about abrogating the dead donor rule to further the wishes of the prospective donor that the organs would be successful. As the earlier they're taken, the better it'll be. And I think once one starts focusing on the trying to follow those wishes and granting them ethical precedence, then a lot of other things can be pushed aside. And I personally don't think it's a good idea, for example, to amend or abrogate the dead donor rule. I think that that's important to maintain, even though respecting it sometimes will make it so that a donation can't take place, because it is important for maintaining, in my opinion, maintaining the public's confidence in the organ donation enterprise, that doctors are not going to be more interested in a critically ill patient's organs than they are in the welfare of that patient. And unfortunately, there is a residual fear of that I've heard expressed, and I certainly read about that, and that by maintaining a strict set of rules of how we do this is important to maintain that level of public trust, even though it may mean that in some cases donors' wishes about donation cannot be fulfilled. So in terms of the more specific one you asked, that it's really the same thing, and that is what changes can we make to accommodate that before we break something.
And I think those were excellent answers. And I just want to add one little corollary, and then we'll come back and get questions from the audience. But what guardrails do you put up? So let's say you know of a center that's actually going to embrace NRP, or even let's just say ex vivo. As we sat and debated some of these issues, we talked even about language, and I hear it coming from you, but I'd love to hear both of you say what guardrails should absolutely be put in place at any center that's doing this so that it doesn't violate public trust, but so it also doesn't get out of control, because we anticipate that as soon as you open something up, people could start gaming things. So I'd love to hear each of you comment. If you had advice, if you were going to design an NRP program, what absolute guardrails would you insist on?
Well, my views on this are relatively clear. But one thing I would say about guardrails is that I have appreciated the way in which the debate over transparency and consent so quickly moved from the idea of right not to know or no need to tell the donor family what happens in NRP, to where now we're actually just, people are having discussions about what are the relevant details, what do patients and families want to know. To the broader organ donation system, we don't do a very good job of informing people what that really means. So in a way, NRP has motivated a rich conversation that goes far beyond NRP about what it means to properly and appropriately inform people about donation decision-making. And I think that's welcome. And to the extent that transparency and consent are guardrails, I'm glad that's happening.
I agree with that entirely. And I think DCDD, when it started, the organ donation organizations and community treated it in a way, in terms of the authorization process, the same way they treated donation after brain death. And it's very different because in DCDD, following someone's wishes to be a donor in that circumstance can alter their terminal illness, the timing of their terminal illness. And certainly see in my institution that that when the withdrawal of licensing therapy may get held for hours or days longer than the family wishes, in order so that the donation can take place, to adhere to the surgical schedule. And that whole question never had been raised during the consent or so-called authorization process. People didn't know that that might happen. So I entirely agree that this has opened the door to re-examining the type of information that should be conveyed during first-person organ donation authorization. In terms of your question about the guardrails, as I said in my presentation, it must, if it's going to be done, they must prove that there's zero brain circulation, not assume it. And that isn't being done in most places now. This technique was pioneered in Papworth, University of Cambridge in UK. And it's done in a few places here, but most of them, to my knowledge, don't. They just clam. And that's really not sufficient.
Keep it. Question over here.
So I believe it was during Dr. DeCamp, your presentation discussing the first heart transplant in 1967 being DCD. So my question is, was there an ethical or moral value change from that time that had made, I suppose, I don't know how to phrase it, with that being acceptable in practice in 1967, where now it has changed to be more questionable or controversial, or was it always that controversial?
What do you think?
Well, first of all, it was done in South Africa during apartheid,
Right.
and there's some issues there. A scholar has studied all the original records and has written an article that I reviewed, a rather critical analysis of that whole process about how the donor came to be a donor. And as it appears, according to this author, that there was some, Dr. Barnard had created some assistance in that person becoming a donor. I mean by, the declaration. So I'm not sure I would want to spend too much time giving credit to that, other than it was the first heart transplant. But the whole process of how it took place, I don't think should set any priorities.
I think your presentation pointed out well that I'm not sure that it was a ethical change or a change in values or norms as much as really the technology created the opportunity for this to come to the fore when it hadn't previously. So I think it may be hard to know the relative acceptance of the cardiorespiratory criteria versus brain death criteria. Which would you say is more controversial right now?
Well, that's kind of interesting. I'm involved in both of them, so I get to hear, the complaints from both sides. But I think the circulatory right now is a little more controversial. And when the Uniform Law Commission, in their process of trying to revise the Uniform Determination of Death Act, had held their hearings and had their testifying and so on, and discussions, it was mostly the circulatory. The issue there about the changes, like should they substitute permanent for the term irreversible, at least in the circulatory, not should there be some consents and so on and so forth. So I think at least in the United States, probably there's more controversy about the circumvention.
And I just will comment, if you go back to what happened in the late 60s, it's fascinating. Those stories are fascinating. You know, I have a stack of old Life magazines that I've gathered through the years about the controversy. And, you know, what happened in South Africa is not anyway a model for what we want to do. And there's been a lot of criticism there. And then there was this rapid push to develop the whole concept of brain death. I know that one of the early surgeons in Texas actually had the sheriff show up and charge him with murder after one of the early transplants that was performed in Texas. And this whole debate rapidly developed, and there was a rapid switch to brain death because of the whole controversy. So, other questions?
Yeah. Hi. Thank you for this. This has been really fascinating. I've attended these colloquies for years, and this is the best one yet. And this is probably for Dr. Bernard Moore. I just dropped my paper. Regarding consciousness, you talked about consciousness, and in a recent article in Scientific American entitled Lifting the Veil on Near-Death Experience by Rachel Noor, she talked about the experiences that people had in their minds, in their souls, as they were dying, and then they recalled them. Would that kind of information be useful at all?
Well, it's certainly being studied very much so. A number of groups are looking at this and pooling. There are many, many stories. There are books written about this, including the one from a neurosurgeon who claimed he was dead and went to heaven and was resuscitated. And there's obviously a controversy about what physiologically is responsible for these. Is it some disordered brain metabolism that produces these ideas about rising up out of your body and looking down on it, and the lights and so on? So it's certainly being studied by a number of groups and detail. I think in terms of consciousness, the main new thing that's been known for the last 20 years is that some patients thought to be persistently unconscious in a vegetative state are really not unconscious, and that one can use functional neuroimaging like fMRI and asking them questions, giving them things to think about, and then monitoring the evoked responses on their fMRIs and comparing them to normal people being given the same paradigm of things to think about, and showing that somewhere around 20% or so, maybe more, of patients who are clinically diagnosed in a vegetative state are really aware, but we can't determine that on bedside neurological examination, but we can see it on functional neuroimaging by fMRI and fluorodeoxyglucose PET scanning. Same idea, functional studies. So that's a kind of big one now about that.
On the basis of what is it? The physician's right to not disclose information, would that violate the patient's or the patient's family's respect for persons?
I come with your path.
Oh, I'll try to rephrase your question. It's just whether you mentioned something about a physician's right not to disclose information, and whether that violates a patient's right to autonomy, in short. I fall squarely on the side of disclosure. And I think that in fact, when we talk about NRP causing us to think more about the way we did disclosure and authorization for donation procedures in the past, it actually reveals more that our past actions looked a little bit more like paternalism than we'd like for them to. And so, while I think there's always uncertainty about any decision, I think really with a patient or a family about how much is right for this person to know. And, in the extreme case, a physician doesn't sit down and literally say everything about a diagnosis, about a test, about even in usual medical practice, right? We always are tailoring it. That said, I still think that in areas that are uncertain and controversial, like this one, the default is more on the side of disclosure. So really respecting autonomy and patients' and families' choices at the top.
Thank you so much for your presentation. I just wonder if you think that it speaks to a systemic problem that while this discussion is still going on, instead of waiting until we have determined by some level of consensus that this should or should not be done, we have instead gone into this patchwork system of people sort of doing it randomly on an institution by institution basis.
Okay.
And as people who have obviously thought a lot about this, do you have sort of an idealized system that would prevent that from happening?
Ooh, what would prevent that from happening?
Well, my suggestion about this, I agree with what you've said. That's an accurate depiction of the current situation with patchwork. There's no sort of leading authoritative idea about this. A similar problem occurred when DCDD started, and some hospitals adopted, others didn't. I remember at our own place, I was on our board of governors of our medical center then, and when we brought that forward, there was, with our chairman of anesthesiology was outraged, and he didn't want to approve it, and some hospitals wouldn't do it. And what changed it was the Institute of Medicine did a big study of it in the late 90s and published 3 books, beginning in 97 and particularly their book in 2000, in which they gave it their imprimatur and said that it was ethical, proper, and we should do it. That had a huge impact on suppressing some of the opposition and allowing for the growth and spread of DCDD programs. Making that analogy, now, of course, the IOM is called the National Academy of Medicine. I think the National Academy of Medicine should study this in the same way that they did 25 years ago, and issue some recommendation from that influential body. They don't have regulatory control, but they're very influential because they represent the greatest thought group that we've authorized in medical practice. So I have tried to interest one of the members in this, not entirely successfully, but I think that that's what we should do next is see if they only do their work because Congress gives them the order. So somebody in Congress is going to have to ask them to take a look at it.
NRP is not unique in that regard either, I would say. Or many times when we have these kinds of disagreements and lack of consensus, we decide, well, let's let everyone individually decide what to do. Maybe that is to our longer term detriment because we lose the opportunity to do things like collect data and study the outcomes in a more systematic way. But that is sort of our modus operandi for areas of consensus sometimes.
So we have time for 2 more questions. Go ahead.
So I was wondering, you mentioned humility as like a non-medical thing that could be used to help determine medical issues. If there's like a non-medical definition of death that could help determine between cardiac and brain death. And then also, you mentioned that like it's choosing an evil, like a lesser evil, because it's creating a greater good. Wouldn't that still be choosing an evil, which would be non-ethical?
Yeah, good. These are great questions. We should have a conversation after an in-depth on the doctrine of double effect. The doctrine of double effect does allow choosing an evil, for a greater good to happen, but only under very narrow circumstances. So if you're interested in this topic, definitely dig into all the scholarship around the doctrine of double effect, various interpretations of it over time. I may not understand fully your first question about humility. I think it's an important concept that's often not talked about in medical ethics or in medicine in general. But I think part of your question was whether we could get out of this quandary by going outside medicine about both the brain death determination and the circulatory or cardiorespiratory death determination. Could we learn anything from outside medicine? I don't know.
Well, I think philosophers have been important in the idea of, not the analytical scheme for determining this. I know some of the work that I did with philosophers at Dartmouth looked at this question of the organism's pull.
That's right.
It's lots of concept, and that's what was the lay the idea of brain death. So not everybody agrees with people.
Even today,
reject that. But
that's right. Philosophy.
We have lots to learn. I know I'm next week giving a talk in not one of the anthropology courses at Dartmouth, studying anthropological studies of death and dying, and they're interested in what our practices are and
compared to others,
other societies. So, there's a lot of inputs that are important now.
My question is, does NRP go against a person's DNR?
Does NRP go against a person's DNR? It's a great question. It's a very focal point of this issue that it's actually a focal point of this issue that certain things, even in DCD, could violate someone's advanced care planning documents.
There are cases, of course, where DNR wishes of patients are either not addressed or more likely suspended, such as someone, say, who's in a palliative care program for a chronic disease or even a terminal disease, who develops an acute abdomen from acute cholecystitis, and they need to have something to relieve pain, and it requires a brief intubation.
Yeah, so there's precedent for...
Yes, that the overarching theme is palliative, but there may be palliative indications for things like intubation if it's brief and if it isn't, and if the goal is to maintain the comfort of bedding. I've seen...
That's true. So there is precedent for it. Yeah, I would say how you answer that question really depends on what you think of those steps of the procedure and what they're doing and what the effect of it is, depending on how you interpret the actions that are taken after cardiac arrest and after the hands-off period. What you think of those actions will determine for you if you think it does violate a DNR order for a patient.
Well, we're wrapping up our time. So this concludes our question and answer time for the evening. I want to give one little comment. We've spent all night talking about death, but we haven't. What I've heard you talking about is actually life. and respecting the limits of life, as well as what's happening with some other transplant and other persons transit life. So I want us all to celebrate life. That if you're not an organ donor, think about saying you have to be an organ donor for all the good that you do. Plug in as a heart transplant professional. And then the last is just a fun degree of thanks. I learned a lot tonight. This was a very, very high-level discussion from two of the real thought leaders in this field. So if we just give them a really